So I cannot see no questions in the chat. Maybe we need to break the ice. So if the Dr. Isom is okay, maybe I can raise one question to Dr. Columbati for breaking the ice and let the audience writing down the questions and formulating them. Just the priority of the order of the agenda. And so I was very interested in the comparison among pediatric involvement in research and in clinical trial and the adult one, because it's true that we never think about the differences, clinical and not only clinical, also ethical, of a research involving patients. So I would like just to ask more details, both about how a child could be involved in a research, also from a ethical point of view, not only on a clinical point of view, and also how in clinical trials the fear from the adult one. Thank you.
Thank you, Mariangela. As a pediatrician and former member of the ethics committee in our region, I was a pediatric ethics committee member. I'm deeply involved in this because it's been in the recent years, 20 past years, that there has been a dedicated pathway for children in clinical research and clinical trials. And the European Medical Agency makes mandatory the development of what is called PIP, a pediatric interventional plan, that has to be developed in order for the drugs to reach, let's say, trials in children and then approval for children. So luckily we have a safety path for children. Unfortunately, a lot more drugs are still tested in adults than in children. And so there were several campaigns in the past year to raise commitment and funding and to sensibilize this, but it's still not enough in many areas. For example, in cancer, where children receive a lot more treatment option, a lot less treatment options than adults. And in rare disease, this has also been the case for several reasons: less numbers, lower need of investment. But we hope that things are going to change. And there is also one critiques that have been made is the fact that it's difficult to enroll children and family in clinical trial, especially if the placebo is the option. Because why would you put your child, or why would a teenager, and we know the difficulty of getting teenagers with chronic diseases involved in care, why would you put them through an experimental trial that you know might not get them the drug? So they have to, see the needle, go to the hospital, get the needle, get the puncture in the vein, and maybe you're not even making them get the drug. So there are a lot of considerations that have to be kept in mind, both from a physician's perspective, the nurses, but also the caregivers, because of course research in pediatrics is important, but again, many more options need to be considered, and even parents need to bring out all the fears, the doubt, the issues, and we have to have more floors to discuss this. And also the children's opinion needs to be taken into consideration. I don't want to say more, but these are just a few issues.
I just want to say something, pick up on what you said. My apologies. You mentioned the word placebo. So for those who don't understand research, they would be wondering, what do you mean by placebo?
Okay, so in certain types of trials, especially the trials that are blindly randomized, so you want to compare a drug product that you think it works, but you have to compare it with a product that is not a drug. So how do you know if you give this new drug to a group of patients, if it will work or not? You have to compare it to a group of people who will not receive the drug. So let's say I have pain crisis, and I think this medicine will work. So I have group A that will receive the drug, and group B that will not receive the drug, for example. But nobody knows who is going to end up in group A or group B, because you might have like a psychological effect. So you might have the same drug, whether a drip or whether a tablet, that looks exactly the same, but one is the true drug, the other one is like a candy. But let's say I'm going to tell Laura, you have a child, and let's say if I can give you the drug, but I'm not sure if he's going to get the drug for real or if he's going to get the candy. We'll know it only after 2 years. So what about, Laura has to think, well, will my child want to come to the hospital all these more times, take something that maybe will not even have a good effect on him, and maybe he will just take the candy, and for 2 years I will have to come with him to the hospital, make him see the nurses, make him do the blood test and everything, and in the end he might just be taking a candy. So do you understand? Not everybody wants to do this or has somebody as concern, or you have to motivate people, and so explain this. I don't know if I was clear and I explained everything.
Oh, I think they'll get it. Yeah, I know about it, so I just wanted other people to know about it. It's great explanation. Thank you. I have one question for. Oh yeah, it will be for you, but it will be for later. So let's give another person a chance. David.
Okay, thank you. I will also have a question for Dr. Colombati. Have you seen some barriers when you will give children the opportunities to share their perspectives? For instance, with the carers or parents?
So let's separate children from teenagers, because that's a totally different issue, and they're more trickier because they want to express their voice, and sometimes they just want to say the opposite of what the parent would want to hear or tell you, and so that's a completely different issue. And in fact, there's all a pharmacology and trial section for teenagers. Children love to express their view if they are asked, and if they are involved with the appropriate language. And so it's very important that, for example, the physicians or the nurses involved in the trials ensure that there is material that's adequate for the children, but also the parents, if they have a child that might benefit from a trial, ask for all the material that the child would want to know, because they have a lot of questions. Mariangela can remember that in that why I participated in research, children wanted to have the material adequate for them and no more. And they had a lot of questions. For example, why do my parents have to bear the burden of what I am going through? So it's important that they get involved and they have enough space, of course, not like an adult, to express their feelings.
Thank you so much. Thank you, and thank you. And I have a last question for Professor Shah, and then I give the floor to the public. Professor Shah, you raised you raised that patients do not want to go to the hospital, which I think you're right. I don't want either. But they also tend not to want to be reminded they are sick. So when looking at for instance, the number for adoption of mobile health apps, we can see that the retention rate can be quite low. So, and I saw your results were quite impressive, where you succeeded to have quite good engagement. So what were the strategies you used to increase the such engagement?
No, it's a great question, and I think that in my experience, I think one thing that I didn't mention was that it's absolutely true that patients are going to use a device to their benefit and don't want it to be something that is onerous, that is taking too much time. So you do need to make sure that your apps are very easy to use. But the other thing what we realized is that when patients are feeling really well, they're not going to use the app. When patients are feeling really, really bad, they're not going to use the app either. And so there's this sweet spot in the middle where I think there's still a lot of good information, but we have to keep that in consideration that when patients are feeling well, that's fine, that's great. We don't want you to necessarily use the app all the time, but we want to use it as a tool. So there are specific times. So, it depends on what you want the tool to help you with. And so we remind the patients, and a lot of what we're doing, of course, is a research study. It's not standard clinical care. But as we get to that point, it still is a tool. It should be a additional piece of data. Just like I said, as my goal is if I was able to build a prediction type of app, something just to give you information to say, this is where you're going, or these are strategies to hopefully help you, then I think that would be helpful. And again, we're definitely getting input from patients. I second the conversation about having kids and young adults and teenagers all giving you the information that they think are relevant, and how that information is expressed to you is also really important. They don't want just numbers. They want different types of pictures and images that are meaningful to them. But to really answer your question, I do agree that patients don't want to have this in their face all the time because it's just a part of who they are. But they do want to have the ability to have a tool that, oh, by the way, I'm not doing great. What am I supposed to do in this situation? So a pain action plan. What are the strategies they're supposed to? Can I reach out to my provider to make sure that I ask this specific question? So it is definitely a good point to make sure you clarify. It's a good point.
Thank you so much. Therefore, then the interest of what you discussed about gamification, for instance. Thank you
very much. And I can see another question in the chat for the Professor Shah. So the tool Professor Shah presented were very interesting. From what I understood, the results that he's getting with adults and children were pretty good. However, is the app for adults supposed to make them more engaged in their treatment and thus temporary? Or is it a whole new way of communicating between healthcare providers and patients?
Yeah, again, I'm starting to touch on this, and I appreciate everyone really understanding this is developing. This is a whole new world where we're going. So what I have been doing has been temporary. And actually, full disclosure, I believe my success is because it's been temporary. We have other studies that have clearly shown that patients using apps, just like when Angry Birds came around, people were all in love with Angry Birds, and then we kind of forgot Angry Birds. Now there's, I'm sure, 50 million other apps now that kids play with. So it's the same thing. I think it's temporary, but I do believe it's a new way of communicating with providers and patients. I think it's a new world. And I think what's going to need to happen is, just like Angry Birds, we're going to need to adapt. We're going to have to come, as we make the apps, we're going to have to, just as I showed you with Quest Explore, which was the pediatric version, we actually have pop-ups and new badges and new things that come into the app. And that gets the kids excited to continue to use it over time. And again, I think it's just because with kids, I feel like they understand that this is normal. Digital communication and digital expression is normal, and digital care, medical care, I think is where we're going. And so my effort is to try and adapt with the times. My kids will be the first to tell me I'm an old guy now. So I'm not necessarily the best person to tell them how to use apps, but the kids and adolescents are, and they're the ones that are telling me that. So I'm trying to stay ahead of the curve. So it's a good point, though. Again, another good point to bring up.
Thank you so much. And I see a question from Guy Young for Professor Kirby. Can you expand on nitric oxide as a treatment? Also, there are patients who choose natural options of infection control in children with sickle cell disease. What success is it, and what are your thoughts on this? If you are still here, Dr. Kirby, no?
Yeah, sorry. I didn't get the second part, but the first part was use of nitric oxide. So we all have nitric oxide in our system, and when you break down red cells and you have you have reduced. It's known that patients with sickle cell disease have less nitric oxide in the system. Which nitric oxide is used to vasodilate or increase the diameter of blood cells. So when what I showed with were drugs that were potentially used to increase nitric oxide and increase vasodilation. So in terms of using nitric oxide directly, I know that in our ICU, there was a physician when our patients would come in with acute chest would actually give them nitric oxide, but it's not, I don't think it's routinely used and it's not used now in our PICU now anyway. But that's the story around nitric oxide. It's using drugs that are thought to increase nitric oxide within the circulation. The second part, you said something about infections. I didn't get that. You're muted.
Excuse me. So the person was asking about infection control and natural options for that.
Natural options for infection control.
Yeah. And what are your thoughts on that?
So, especially now in the pandemic, in terms of things that you can do with good hand washing, always is across the board and in or outside of a pandemic. So I suspect this is the question of, instead of using prophylactic antibiotics and vaccines early in life to prevent encapsulated organism infections like pneumococcus, meningococcus, if there are any natural things to do to prevent that. Other than good hand washing, and avoiding people who actively are infected with anything. From my knowledge, there are no natural things. Good hand washing, bathing so you keep yourself well. A good lifestyle in terms of exercise, so you have good lungs. But really, even if you had great lungs, good health, if you were to get infected with pneumococcus, it could still make you very sick. So that's why we say anybody who has a fever with sickle cell disease, even if they've been vaccinated, even if they're on prophylactic antibiotics, must be taken to emergency.
Thank you very much. Dr. Plegini, I don't know if you have some other questions.
Not personally.
I have one. Sorry, I was typing it out, but I'll ask it. This one is for Dr. Shah. In my mind, I'm thinking when you go to hospital, they will ask your pain score, and they'll say from 1 to 10, how is your score? For a sickle cell patient, sometimes they go above the 10, so they have a higher score. So for the app, you're getting scores that you told us 5 point this and 3.5, unless I didn't understand it very well. How do you compare the two scores, the score that you get from the app to the score that is used in emergency departments?
Yeah, I mean, you're bringing up a really good question in the sense that there is no gold standard for pain outside of what the patient says. And so there's no lab value, there's no monitoring I can do. I have to rely on the patient's pain score. And patients can go both ways. I mean, I've seen, I think we know patients may overestimate their pain and they may underestimate their pain. But what the patient says is typically is what we have to go by. Now, quality of life measures give you many times a better reflection. So if you do a patient-reported outcome or a quality of life assessment, you get a better assessment of what that pain means to that patient. But again, to answer your question, we are relying on using the pain scores over time. So not just one time point, but we're asking every hour to every other hour how your pain's doing in the day hospital. Just to come, we're reassessing because we're giving IV pain medications, and we use that as the standard. So when we predict that pain score, we're using that as a reference point. So in our 70% accuracy that we found in that one study was to that value that the patient said. And so, the pain score, that if the patient says that they have an 8 out of 10 pain, and then our computer tells us that based on what the wearable says that it's 7.8, it's pretty precise. It's pretty close. And so we're doing a pretty good job of that. I think what you're bringing up, and again, without taking too much time here, is just to say that there's been pushback a little bit on both sides about trying to be careful about predicting the pain, because as you're mentioning, the patient has every patient has a different context of what pain means to them. Every provider has a different interpretation of what that pain means to that specific patient. So how can I use a computer to then just predict this is what your pain is? And I want to absolutely make clear that our job is not to predict the pain score. My job is to provide a prediction of what might be going on. It's just like getting a lab value. If I get a blood count and your hemoglobin is this, there's plus or minus error to it, but it's also just a piece of who you are. I mean, if your hemoglobin is, for a patient of mine, sickle cell, who has a hemoglobin of 7, that's okay. But what was it before? Where is it going? What else is it? Is there also signs of hemolysis? So I have to take all of this information together, and that's where this digital information hopefully is just another score or evaluation to give me information. And so I do want to get away from just the pain score, but I do think the prediction of how a patient's going to do can be helpful.
Thank you. Excellent. And also, Laura, I think it's a good question, because you raised this issue of quality of information, which is difficult to solve. Huh? We didn't yet. And I was thinking, Professor Shah, do you think it could be relevant to add some depth of data, for instance, for pain assessment? It could be the speed of increase of data, or the location of the data, the focus, something like that, or maybe if it...
Yeah, all of that is very valuable, and I actually agree that it's not just the pain at any given moment. That was the study I showed, but we're really interested in where is the pain going, like what's the trajectory, where is the pain in that patient? Is it a typical site, non-typical site? But there's so many nuances that it gets really complicated. So I've been taking pieces of it and trying to put the puzzle together, but it's very complicated, and I appreciate everyone understanding that we need to keep pushing and understanding how complex it is.
Thank you very much. I can see another question for Dr. Shah in the chat, so I'm going to read it. When will the pain simulator for care staff be ready, so non-sickle cell disease person can get sense of how intense our pain is? And I continue the question, with proliferation of wireless digital tech in Africa, how can it be used to improve quality of care and life? Thank you.
Yeah, I'm so thankful that you're bringing this up, because this is something that comes up every single time I talk to patients and their experiences they're having, let's say in the emergency room or otherwise. The strategies we give patients is to minimize the pain to them. And so when they come into the emergency room, that sometimes is interpreted the wrong way. When you know, when I tell patients to listen to earbuds so that they distract themselves, and then the ER says they look fine, it's not a reflection of how they're doing. And so can I take this wearable data and say, look, this is really what it looks like this patient's doing? That is absolutely what I hope to do. That's part of giving another assessment to a medical provider and saying, you know, yes, look at the labs, yes, look at how the patient's doing and examine them and everything else, but also look at this digital signature, like this is what your patient's doing. So the question was, when will it be available? There are still several steps because I'm on the realm of being a device, a medical device. There's a lot that I have to go through, and you know, to provide a medical device, I have to go through all kinds of clearance. So I'm doing a lot of this in the research world. Can I bring that to other places? Absolutely. I am very much looking forward to bringing this research, because it's digital. It's so easy to bring to different areas. And that's why your question about you know, wireless digital health in Africa as well is very relevant. I mean, this is something now I really think can be provided, even a very simple app or a platform that can provide patients with information, can be given to anywhere in the world that has access to the cloud, right? So any cell service, any internet service, even if it's intermittent, can have access to these apps, because the apps are now living on the devices. So I think we really are in a great place, and I think that having this come to Africa, I know specifically, at least one of my colleagues, I'm working with her to bring it to Sierra Leone, and I know that other areas are looking into this. So I'd love to keep in touch with anyone who wants to continue the communication, and I appreciate the interest.
Thank you so much. Elizabeth, you have a question?
A very good afternoon to everyone. My name is Elizabeth Karoma. The question is for Dr. Melanie Kirk. Is Dr. Melanie there?
Yes, here.
Okay. Yes, you spoke about research. I wanted to emphasize on the subject of what are the key areas in research that have contributed to the well-being of patients in Europe. I know you've said a lot on it, but if you can just emphasize on a few key areas that we can take on board today.
So I practice in Canada, so I'm not as familiar with what drugs have been approved within Europe. What
Yeah.
our other speakers might be more familiar. Was that most of what you wanted?
Yes, I know we've got some few new drugs, but in terms of research, what are the key areas in research that have contributed to the well-being of patients in a way? In Canada, are you based in Canada?
I am, yes.
Yes.
So going back, the key areas would be going back from early newborn screening is probably, and comprehensive care, first of all, recognition for comprehensive care being most important. And then with once you have newborn screening and you have a comprehensive care program, it makes no sense having newborn screening if you don't have a follow-up comprehensive care program to follow these babies. Infection prevention with pneumococcal, particularly pneumococcal, meningococcal vaccinations and pneumococcal prophylaxis with antibiotics are key in the first few years of life, and has been for all over the world. And because it allows kids to get past the first 5 years of life. In many parts of the world, that is one place, one aspect of care that affects them. In parts of Africa, malaria is huge in terms of infection. In North America, not an issue although we do have a patient admitted now with malaria, with sickle cell disease, but recently coming and having just traveled. One of the big things in my time has been stroke prevention and use of transcranial Doppler screening and stroke prevention. We have seen strokes, practically no strokes in our patients since we've been doing transcranial Doppler screening. And I think across people who do transcranial Doppler screening have also reported that there are occasional breakthroughs, but for the most part, no. Once we've had the management of been allowed to follow through with management of patients, I should say, because on occasion we have parents who refuse transfusion therapy, even though it's for a shorter time now, and hydroxyurea for together to prevent stroke. The use of hydroxyurea has been probably one of the biggest research that has been done, and an institution of hydroxyurea in patient care, because we've seen kids participating in sports. We've had great, I think people's whole lifestyle quality of life has improved with hydroxyurea, and the patients who are on should have tested this, or if with good compliance. The other newer drugs, the voxelotor, glutamine, and crizanlizumab, those we haven't had access to those because of cost. I don't see us in Canada going to those because we are not a privatized healthcare system. So money for like bang for buck, it's expensive, and we may be able to for an individual patient with private insurance, but even for the private insurances to cover it, it has to be recognized by our Health Canada. The other things are one of the things that I didn't talk about because it was sort of therapies. One of the big things, and it has come up through Dr. Shah and some of our other speakers, is the quality of life and the psychological aspects of care of patients, which people are recognizing now. And because even though we have patients who are well established on hydroxyurea, we get quite and outwardly doing well, meaning not coming in to hospital, not coming to see us, and so on. Many of our patients have depression, and on occasion we have patients who develop a depressive illness for just by virtue of having sickle cell disease and worrying about the future and so on, and then they start having pain, which is they've experienced pain, which even well established on hydroxyurea. So that's an area that we try to, with the help of our social worker psychologists, try and help with managing patients.
Thank you so much. It's very helpful to know that the well-being of patients have been monitored in terms of mental health issues and all of that. Quite grateful. But I believe also that we are we are now drifting into more of digital in a way. So I quite agree as well with the doctor from North Carolina. I do agree with your app. You're doing a fantastic job out there, and I just want to commend that and to see that is something really in terms of like what's happening now in COVID, and COVID seems not to go away and all of that, but that's really good. Thank you so much.
There is Miss Larn Tuni Ajay that has a comment.
Yes.
I think we have a few minutes for the last comment or questions.
Thank you, Maria Angela. It's nice to see you again.
Same for me.
Thank you. So I just wanted to thank all of the speakers for this session, Dr. Kirby, Dr. Raphael Colombati, and Dr. Nim Shah. And I want to mention that, as we know, sickle cell disease is more prevalent in low-resource countries. But we find that patients in the high resource countries have better quality of life, mainly because, of course, partly because of innovative therapies, as Dr. Kirby has rightly put, there's better participation in clinical trials, as Dr. Colombati has also alluded to. And also with Dr. Nimshishir, I believe that there is a better opportunity for healthcare providers to share knowledge among one another. Knowledge translation is more common in this part of the world. So my comment is that it's very important that we extend knowledge translation to low resource countries. This is why we have the highest number of patients, people who are affected by sickle cell disease. And it's very important to ensure, even through apps that they can access through their phone, everyone can have, everybody, I'm sure in many countries, even in Africa or South America, have phone, that if they can have access to education through this app, I think it will help to improve, the quality of life of many patients, even in the low resource countries. But I want to say thank you so much for such a wonderful presentation. Thank you.
Thank you, everyone. I'm just waiting there to see if David, we have one of our members who represents Federation Source Globe. I think she wants to ask a question. So David,
Yes,
do you want to ask just that quick question?
Yes, just, I don't know if it's Jenna or someone, you can ask your question, please.
I don't think they can be heard because this is a speaker only, so they wouldn't be heard here.
Alors, Jenna, tu peux m'écrire dans le chat si tu veux et je pose la question. Qui c'est Jenna? Je ne sais pas qui c'est derrière.
In the meantime, I think Dr. Colombati has left. I wanted to mention a point where she said some research takes up to 20 years. So if they are doing some research for treatments in sickle cell and it's taking up to 20 years, and then at the end of the day, it's not approved, what does that mean to the company and to all that effort that is being put into the research? Anyone can answer that between Professor Shah and Melanie.
Okay, so sorry. So the question raised by the Fédération SOS Globe is that they raise doubts about the usefulness of the app on the long term. It's a question for Professor Shah, sorry.
Yeah, no, I agree. Over the long term, you're going to see a drop off in the use of the app. I think that there's a place, right? So that if you think about it, we use prescriptions for medications, and we're even now starting to use prescriptions for remote monitoring, like an EKG monitor, a Holter monitor, where patients go home and are monitored. So, I imagine the same thing is going to happen where we're going to want to write prescriptions for digital health. And so I think there's a place for it. I do not think it's necessarily for everyone. I don't think everyone's going to want to have it, be used every single day. I think it's a tool. It's a tool that either your medical provider will feel like there's a place for. I think that there's a place that the patient may feel like it's useful for. But I agree. I think everyone is not going to use it 24 hours a day. It's not realistic at least in the near future. Again, maybe our kids will grow up into that type of world, but not in the near future. And I guess it says it's coming up. It may allow patients to be dependent. I think, again, we have to be careful. You're bringing up the pros and cons of everything, and I think we're not to the point of making this standard of care, and where we're using this in research. I understand the hesitation, and I think that what I'm trying to do is push the envelope to say, what can we do with this, and then try to figure out how to best leverage the technology. Again, is it specific situations? Is it prescriptions? Is it in an environment where you were just in the hospital and I really want to watch you very closely because I know there's a high rate of you coming back to the hospital? So I do think there are places. Does it make you dependent on that? I guess I think that's for debate, and I hope that the patients and advocates that I work with on my research team, because they're part of this, would continue to give me advice that this is becoming more of a nuisance or more of a problem by making the dependent. But I do think a counterbalance argument should always be had. So I appreciate that. The other question that was brought up very quickly, and Dr. Kirby-Allen can speak to this as well, is just, it was brought up about it taking 20 years for research. I do quite a bit of research here in new drugs too, in the United States. I think that we're finally to the point that pharma companies are doing much more research they are now in the last 5 years than they were in the last 20 years prior to that. So I think there is an acceleration to the types of research being done. So I do see more phase 3 studies coming down the pipe. There's actually 3 phase 3 studies I can think of that are starting in the United States right now. And phase 3 are just larger randomized placebo-controlled trials in adults. So I think that the rate of acceleration is promising. And I just want to say one last thing, which is I'm just happy that there are now options for sickle cell where we used to just have hydroxyurea. I think we're in a world, if you think about hypertension, diabetes, congestive heart failure, all these other diseases have multiple medications. So why does sickle cell, which is a very complicated disease, why would we not have options? And I think now we're finally starting to get that in the near future.
Thank you very much, and thank you everyone for your question and
if I
that,
can
yes.
stop you, I'm sorry. There is one very last question in the Q&A session. Been just notified. Sorry to jump like this. I will recommend a very quick answer because we only have last 2 minutes. So what is the pain option for sickle cell patients, as hydroxyurea is not recommended, but only for SS people?
Are you asking, is that a question about preventing pain? So it's people who have more severe sickle cell disease use hydroxyurea, recommended as S-beta thalassemia, but SC and S-beta plus thal and other less clinically severe, usually sickle syndromes, if you are having VOC pain, vaso-occlusive pain, hydroxyurea is useful, and there are patients that we have with SC disease and S thalassemia plus thalassemia who are using hydroxyurea with good benefit. I just raised my hand just to say one thing. My request was to speak about research therapies. Don't underestimate and don't expect only drug therapies to give good health. A good lifestyle, exercise, healthy, our Canada Food Guide, your European Food Guide, exercise, doing activities, being social, all of those things that we've been denied in COVID are also good for families, and because for an individual patient. So don't only rely on hydroxyurea and sit down and do nothing. Exercise, interact with family members in any way you can, virtually or whatever. Doing mindfulness is mindfulness with our little kids when they're in crisis, and I try to keep it in the clinic so that they can do it at home. We certainly use it in our sickle cell camp, which we ran prior to COVID in the summers, when we're out there up in the bush with pain, and as an adjunct therapy. So medication isn't the only thing. That's all I just wanted to say. Learn a new skill, learn to paint, learn all these new things which are good for all of us, and including our patients.
Thank you very much.